Hello, everyone. My name is Mukesh Jain, and I'm the Chief Academic Officer for University Hospitals. And it's a real pleasure for me to be with a very special guest today, Dr. John Lewin. Dr. Lewin is the Executive Vice President of Health Affairs at Emory University. He's the Executive Director of the Woodruff Health Sciences Center, CEO and Chairman of the Board of Emory Healthcare. Dr. Lewin is also an alumnus of University Hospitals, and over the years has made enormous contributions to science and medicine, both as an investigator and as a healthcare leader. And we're very honored that he accepted our invitation to visit University Hospitals on September 30th to deliver the inaugural lecture, which we've entitled the UH Alumni Healthcare Leadership Lecture. So with that as a way of background, welcome, Dr. Lewin.
Well, thank you. And it's a pleasure and an honor to be able to join you today and your alumni who hear this podcast. So thank you so much for the invitation. And I'm very much looking forward to coming and visiting my old alma mater at the end of September. It's been too long since I've been there.
Yeah, well, the feeling's mutual. There's a lot of excitement and a number of colleagues that you trained with, John, that are still here, and they have all been reaching out saying, I want a few minutes with John when he visits, so it'll be great. Let me get started. And you trained here, but actually you grew up in Cleveland. And can you tell us a little bit about your family, your childhood growing up here? And as I understand it, you still have family in the area.
No, absolutely. Well, as you say, I grew up on the east side of Cleveland, and my father was actually, as we used to call it, a general practitioner. So he had an office down on Chester, right around 101st and Chester, where he took care of people from the neighborhood. After medical school from Western Reserve, where he graduated, he did an internship at Mount Sinai Hospital, which is many people will know as a Cleveland landmark until not that long ago, and then did residency in Boston, and then went off to the Army and was in World War II, was stationed in Europe in World War II, came back, set up a practice in Cleveland. And so as I was growing up, he was delivering babies out maybe 3 nights a week, delivering babies, making house calls. He literally we would run into people. He'd delivered 2 generations of families. And at one point, some of his office mates were moving out to the suburbs saying, hey, let's get out to where there are wealthier patients. And his answer was, well, if I leave this neighborhood, who's going to take care of these folks? So he stayed, again, down in taking care of an East Cleveland and a city of Cleveland patient base. So I grew up with him as a role model. And my mother, who is a master's degree trained also at Western Reserve University in library sciences, ended up really working in his office and helping him out. So growing up, was great. I had 2 older siblings and enjoyed really Cleveland and learning the city and spending time. But Case Western Reserve University Hospitals area, something well known to me as I grew up.
Well, that's beautiful. And, your comments about your father, that is the classic practitioner, right? They could do it all, which medicine has changed a great deal since then, but that is very inspiring. And in addition, undoubtedly, your father was an inspiration for your interest in medicine. Were there other mentors or inspirational figures for you growing up in Cleveland?
Well, interestingly, I never thought I would be a doctor when I was younger. And part of it was every time I'd see someone, they'd always say, are you going to be a doctor like your dad? And, the answer was, of course, was, well, no, I'm going to do something different. And I was very interested in science. I was actually a real nerd. And interestingly, the summer between 7th and 8th grade, there was a program being run by a Case Western Reserve University professor teaching middle school kids about computers and computer science. And I don't know why he did it. I think now as a faculty member, how selfless to get, there were 3 or 4 of us. We'd ride our bicycles down from the east side on Sunday mornings. sit with him, and he'd teach us, actually had a book on calculus to teach us some of the basic underlying ideas, and then would work on coding and got us accounts on the old PDP-10 that was sitting on campus. And so I learned how to program, in again, between seventh and eighth grade. I actually got a paying job at a place called Chi Corporation, which was a Case Western Reserve University subsidiary, I believe, that did a large, mainframe computer analysis. So I got a job working there and writing machine code for their operating system, and it was a great experience. Got me into the technology and the science, and I actually grew up thinking I was going to be a scientist, either a physicist or engineer, something along those lines. And it really wasn't until I was in college, I was a physical chemistry major working in the lab, when I started to see that maybe there were things I could do that would merge my interest in discovery with medicine, understanding that having a bigger impact might be something I'd be interested in today. So, as I started to think a little bit more about medicine, I got a job one summer at Mount Sinai Hospital working as an OR tech. So I was a scrub tech. I was, scrubbed in surgery. Things were a little different back then. I don't think a college summer student, could now be in an operating room. At least I hope not. Certainly, that seems a little bit less likely. But I worked in an orthopedic surgery operating room and really started to think, if I went to medical school, I could do research. I thought it would be in biomechanics and work, become potentially an orthopedic surgeon, and decided to go to medical school. And that was really what changed my mind, the idea that I could have a bigger impact as a physician scientist than as a physical scientist in the course I had initially been heading toward. And in fact, I had not taken any biology in college up through my junior year. So I had to quickly take an intro bio course at Cleveland State University during the summer, and then ended up, taking what I needed in terms of biochemistry and the other bio prerequisites my senior year of college.
Well, I'm in awe of anyone that majors in physical chemistry. That's remarkable. That was the hardest class I remember, for me at least, in college. That's amazing. So you finish college, you go to medical school, and you came back to UH for residency in radiology. And what influenced your decision to come back to UH at that time? And what stands out to you about your experiences as a trainee here?
Well, it was interesting in deciding. I looked in two locations. I looked out in New England, which is where I trained, mostly Boston and New Haven. And then I looked at Cleveland because my parents were living here, and thought, well, that would be also a good opportunity. And what was interesting was, at the time, not all of the diagnostic radiology programs were in the match. So I actually got offered positions up in New England, and University Hospitals was in the match. So Dr. Pat Bryan, who was the chief of ultrasound and was the program director, essentially said, you have a really good chance of getting in here. So I had to turn down the positions on the East Coast to put myself in the match. And sure enough, he was true to his word. And though you weren't allowed to say you're in, but he came as close as he could. And I ended up coming down to UH. And the real difference was, and there were some great programs, but many of the programs I found residents sitting in libraries reading. And at UH, the residents were actually doing things. They were doing biopsies. They were doing their own ultrasounds in the ultrasound suite. They were really much more hands-on and involved, and much more responsible for the diagnoses, for what they were doing, than I found at most other programs. So really, it was the hands-on, involved aspects that drew me to UH. And when I got here, or when I got there, I found it was the right decision, because what I found was what I had anticipated during the selection process.
That's great. And were there mentors or colleagues as you reflect back that you were particularly influenced by?
There were some really great colleagues. It was the days of big personalities, and I think any of the radiology alumni that hear this will also agree. And there were just great people. There were people who were really dedicated to teaching. Barry Eulish in pediatric radiology, Stuart Morrison, who was there. There were people like Pat Bryan and Alan Cohn and others. Just really enjoyed teaching the residents. And then there were some real inspirational folks. John Haga, who I understand just recently retired. I have to say, if I had to pick one person who was a role model at UH during those days, it would have been John, because John was and probably still is about moving at 150 miles an hour and always thinking of creative things. And what I really enjoyed was he was always thinking of crazy ideas that people would listen to and say, that is impossible, that would never work. And then he would take all the time it took to prove, yes, in fact, it would. Things like CT guided biopsies, core needle biopsies. People thought he was dangerous when he started them a few years before I got there. And we became proficient in doing these based on John's real mentorship and modeling.
Yes, you're absolutely right, and he's continued to remain very active, as you have alluded to. So you finished up at UH, went off for additional training in Germany, I believe, and then returned to the clinic for an initial faculty position, and then you came back to UH, and that was, if I recall, sort of an interesting time, because there was strengths in the MR, but a group had moved around that time, and you had to come in and build an MR program essentially from scratch. And tell us a little bit about that process, the lessons that you learned from that, and how they might have impacted how you've thought about leadership moving to other aspects of your career.
Sure. Well, during my residency, the other really impactful group that I worked with was the MRI research group. And at the time, there was a very prolific group of both physician scientists as well as PhD scientists. And I ended up doing a lot of work, a lot of research with them during my residency, and really got the academic bug during that time. I went off to do a year's research fellowship in Germany, in Erlangen, at what was at the time, the Siemens MRI Research and Development Center, in a program that university hospitals had developed with Siemens. While I was gone, the physician group that I'd worked with moved over to the Cleveland Clinic. In part of the back and forth, which seemed to be in radiology, much of those days were a lot of back and forth. And shortly after I returned, actually just before I came back to UH on faculty, the PhD group departed and went to WashU. And all the postdocs and PhD students and faculty pretty much upped and left. So when I got to UH, again, I had a big, nice building in the basement of Bulwell, a couple of MR scanners that I was responsible for from an administrative perspective, a great clinical MR tech staff, but essentially no scientists. So I hired a programmer. I got a little bit, actually didn't get much startup. I didn't know I should ask for startup funds back then, but I was able to scrape up enough to hire a programmer and to start doing some MR research and programming, as I had learned in my research fellowship. And one of the best things that ever happened was Mark Hakey, who was the PhD who had left and had taken the group with him. As I talked to him about rebuilding, he said, there's a young scientist, MR scientist, who's working over at Metro, I believe at the time, or Mount Sinai. I actually don't remember, how I'm embarrassed to say. but you ought to talk to him about coming over to UH. And so I did. I recruited by the name of Jeff Dirk, who came and joined me. And really together, we went out, got grant support, I actually, just before Jeff, I hired another programmer, a second programmer. And when Jeff joined, that programmer went to get his PhD with us and stayed on. And by the time I left, there were about 25 people working in the MR group. When I left Jeff continuing to move the group forward. And as you probably know, he went on to then be the chair of biomedical engineering, and then the dean of engineering, and now he's provost down at the University of Miami. But really, the opportunity to sort of build a research group from scratch and to recruit people that not only were smart, but also shared sort of commitments to mutual respect, to excellence, to communications, to really build a culture was an incredible opportunity that it never would have been there had there been a big existing research group. And the other thing about UH in those days was there was also a group of great collaborators. At the time, Mark had left a group of psychiatrists and neurologists interested in brain functional imaging, which was very new. And that was an area that I had helped start up at the clinic. So I was able to sort of slip myself into that clinical research group and to provide the technical side of that work. So it was a fertile blue ocean for really building what ended up being a very fulfilling research career.
Oh, that's great. And you built a remarkable program that continues to this day, as you know, and along the way, trainees, etc., great contributions to science. And as I understand it, there were also lighthearted aspects of your engagement in Cleveland. And I'm told that you were part of a band or some sort of musical group, and maybe if you can share with our audience a little bit about those experiences.
Oh, sure. Well, it was those were fun days, and actually, I think I started that while I was still a resident. Started working along with them, but continuing on. But actually, your very own famous Dr. Warren Selman was actually probably the core. He was the key to the band. He was the vocalist, lead guitarist. We used to rehearse at his house. And it was a UH based band. We had a neuroradiology fellow, actually, who had moved over. I think he might have been at the clinic at the time, but had trained as well at UH, who played rhythm guitar. We had a colorectal surgeon on drums. We had an oncologist on bass, and I joined on saxophone. And typically, we would have also vocalists who might be an ED nurse, I think was a person who was one of our vocalists at the time. And we just had a lot of fun. We'd play, I would say not the highest classes of establishments, but we had a lot of fun playing. And I can't give you the name because we used to change the name of the band. We used to say it was so people would come again to hear us. We would change our name. But we went through several names: LD50, the Specimens, the Retractors, which I think the Retractors continued on after I was gone for a while with that name, but they continued for quite a while. But we had a lot of fun, and again, I believe Warren is still playing his guitar, and I moved on to jazz, which I enjoyed for a while. Before I left, I was playing with a small jazz group in the atrium during lunch times at UH, and actually continued that with a quartet at Johns Hopkins for my whole 12 years there, and have now gotten a little group together here periodically pre-pandemic at Emory as well.
Wow. Well, that's fascinating. So that music has remained a thread throughout your career. That's really wonderful.
It is one of the more fulfilling things for me.
Yeah. So you mentioned Hopkins, and so I was going to transition forward. After building the program here, you left to take on major leadership roles, chair of the Department of Radiology at Hopkins, and then eventually CEO of Emory Health some years later. And can you share with us your leadership style? What are the principles that have allowed you to be so successful in these major leadership roles?
Well, and I want to emphasize the success we had at UH with our research program was really, Jeff, Dirk, and I working together. I mean, it was really the team building of that program, which really helps. And we had, a fantastic time recruiting really great postdocs from Germany, from Egypt, from Iran, from really, it was like the UN down in the lab with our research fellows or our graduate students from China and India. It was just fantastic time. And really, sitting as a physician scientist, the opportunity to build a culture down in the lab was really helpful in figuring out what were the most important aspects of a successful endeavor. And I think the lessons from a research physician scientist career to being CEO and executive vice president for health affairs here at Emory, it's really the same fundamental concepts. And the first of them was that there are a lot more smart people in the world than good people. So the key was to find a good person who was really smart, as opposed to just finding a really smart person. And I used to say the productivity of the group was essentially divided by the number of negative or nasty people you had in the group. So if you had none, you had infinite productivity. The minute you had one, you brought it down. And if you got more than one, you were really in trouble. So we spent a lot of time looking for people who were not self-centered, who really are team players. It was the days before the term team player was really in vogue. But in fact, that's what we did, was really assembled a group of team players. And at Hopkins, it was really the same idea. It was trying to create a culture where people looked at what was best for the organization, what was best for the department at the time, and how do you maximize the impact and productivity from, in particular, the research. And the reason I think I was recruited there was really because of vision around how to build a research culture of success and how to maintain a research culture of success. I had the unenviable task of following Elias Zerhouni as the chair of that department. And as I was going, people essentially said, what are you doing? There's only down to go, from that position. And in fact, over the ensuing years, we doubled our research programs. We more than doubled our clinical programs, built a, very successful business, imaging business on the outside that helped fund the research mission. And so it really was a great opportunity. And there are a few things that I learned, I think, at Hopkins that have been helping me here. I learned from one of the CEOs of one of our hospitals. He sort of gave words to something I'd been doing, but sort of the framing helped me think through it. And that's, really, I like the idea of calling it, sort of a tight, loose, tight leadership style. And the tight part at the beginning on the top is to sit down with direct report, whoever it is that's going to be doing the work, and spending the time to very tightly define, why are we trying to get that done? Why are we developing this program? Why are we moving in this direction? And to make sure that, the folks who are doing the work understand the why very clearly. And then to work together to make sure the what needs to be done is clear. And the clarity is really the one of the biggest keys to that. And then third thing in that first part is to together define metrics. How are we going to know whether we succeed or fail? And to be very clear and to work together to essentially co-produce a set of clear metrics. And then, assuming you've hired the right people, I would say, okay, go do it. And the how it gets done is really, then up to the person, the report, the dean, the chief operating officer, whatever level it is, the division chief at Hopkins, and then to come back for a tight, so that's the loose part. Go ahead and do it. When they're done, come back and sit down and say, okay, where are we relative to the goals we set? And, if we've succeeded, that's great. If we failed, why is it? Is it because the goals were incorrectly set? Is it because the resources weren't provided to do it right? Is it because the person who was doing it didn't have the right skill set and they needed to further develop? And again, failure is not a failure. Failure is a reason to sit down and decide, what do we learn and how do we move forward from here? If every project is a success, we're not trying hard enough. We want to have some failures there to be able to say we're really stretching and making a difference.
Yeah.
And that sort of had become really the way that I've looked at the world in the leadership positions. And then the second part is the willingness to really delegate. And that's something else. As the organizations that I've led have gotten bigger and bigger, it's become key to know how to delegate. And again, the sort of tight, loose, tight helps, because the how, you need to fight the initial urges to micromanage, because we all get to our leadership positions because we're good managers. And we know the how we would do it. And the key is to let that go, let the person develop their own how, and not to micromanage. To micromanage is impossible. I have about 36,000 employees right now. If I tried to micromanage almost anything, I would grind to a halt. So it's really getting the right people on the team, giving them the resources they need, and letting them fly.
This I think dovetails well with where I wanted to go with the conversation, and it reminds me your comments of something that I've heard you emphasize in other venues, and some of this might have been maybe annual addresses that you've done at Emory that are available and I've had the pleasure of viewing. And you talk about 3 critical areas: strategic clarity, effective architecture, and constructive culture. And you just spoke, in the last little segment about clarity and culture. I want to expand on the culture, because that's something that I think, as I've understood, you care very deeply about and you have emphasized. So tell us about the importance of culture in an organization and how you've been able to impact that, be it at Hopkins and certainly now at Emory.
Peter Drucker, who again is a sort of venerated business voice over many years, once said that culture eats strategy for lunch every time. And it's really true. The culture is probably the most important part of an organization, and it's the most difficult to change. So, for example, the idea of emphasizing strategic clarity, effective architecture, and constructive culture, that really, from a change management perspective, it's all about communication. So I started my first year, I kind of sitting down thinking about one of my first addresses, came up with those 3 ways to sort of crystallize what I thought were the most important parts moving forward. And every annual address I gave and every CEO forum I gave at one of our hospitals, or I hit on those 3 themes and reinforced until I heard our teams using those words. It became part of the lexicon. And again, the strategic clarity was the first part that I worked on, because we really needed it here. I think it was true at Hopkins too, although I didn't have my own clarity about how I would approach it. Here at Emory, creating the strategic clarity was really the first step, and then restructuring the organization to be effective was the second. But really, the constructive culture has been the quest I've been on. It was the quest I was on in the department at Hopkins, where I feel good about the culture that we built as an academic department. And here, it's really been even more a conscious effort to move the culture in a positive direction. And I think one of the important things about creating constructive culture is never to say, well, the culture, wherever you are is not good. Because every culture, that is the organization. And that's a mistake some people make. What you have to do is look at the culture of the organization and say, what are the best parts of this culture? And how do we emphasize those and grow those pieces? And what areas do you need to introduce to continue to move the organization forward? So we've made some real progress here, again, based on a real collaborative group, a very friendly culture that I inherited down here, but did a few things to try to really move things forward. And one of them was to go sort of head first into lean culture transformation, using lean process improvement measures, not just the tool set of doing waste reduction through value stream analysis and other sort of specific tools, but really to create a culture of inclusiveness where the employee on the front line can have an idea or can identify a problem, and that goes all the way up to the C-suite quickly. So we created daily huddles. We have about 1,000 daily huddles on every work group, and by 9:45 a.m. every morning in the C-suite, there's a tier 5 huddle. It's gone through multiple tiers, and any problem that's been identified that hasn't been resolved at one of those lower levels, we hear about every day, and we can help figure out what resources are needed at what levels to resolve them. And it's then creating a feel of inclusiveness where our frontline staff, they know if they come up with a good idea, it's going to be listened to. And that makes a huge difference. So it's really creating a culture of valuing every opinion, of valuing every employee, of empathy and compassion for everyone at the organization, that helps move things forward. Creating and emphasizing and reinforcing respect across the board, creating a fair and just culture where everyone can feel respected, and really to create a culture where people realize that before you make a decision about a business plan, a strategic investment, or whatever, you ask the questions first: is it what's right for the patient and their family? Second, is it the right idea for our people, for the team? And only if the answer to those two questions is yes, do you then look and say, does it make sense from a business plan perspective? Is there a margin on it? Is there a strategic imperative to get this done? And really making sure that people always put those first two questions first is another piece of building what I believe here has been a real constructive culture. And it's a journey, and there's still a long ways to go. In particular, we have an emphasis now on diversity, equity, inclusion, and justice that we've really been working on. We started it my first year here, but have really accelerated the look we're doing, the sort of honest introspection we're doing as an organization, and moving forward in that respect as well. And that's, something that's much needed, especially down here in the South. It's been a journey that also is worthwhile, but certainly not easy.
Well, thank you. Those are really fabulous remarks, and I certainly think our audience and the leaders that will listen to it will benefit greatly from your experience and what you've done at Emory. I was thinking as you were speaking that despite all the leadership experiences that you had and remarkable success, that leadership skill set had to have been tested in a way that even you could not have anticipated over the past year. So we've all been dealing with the pandemic, incredible challenges at a personal level, at an institutional level, at a societal level. What leadership skills did you draw on to deal with the challenges overseeing just 36,000 employees of a huge academic medical center?
I think really my approach in the pandemic, I think, was in large part predicated by sort of my underlying philosophy, and it's best stated through a quote Winston Churchill, said, which is a pessimist sees every opportunity as a problem. An optimist sees every problem as an opportunity. And I'm fortunate that, sort of throughout my life, I've always been on the glass is 3/4 full end of things. So seeing the pandemic arise and watching it very carefully and closely, and then working to mitigate the incredible challenges that it's caused here, in Metro Atlanta, here in our organization, obviously this across the country and around the world, really coming to it with the optimism to say we can make a difference here. We can really make a difference as an organization, and we're going to beat this thing. And so going in with that kind of understanding sort of made it easier. I don't think anyone on our core leadership team had a day off in the first 6 months. We reorganized as most major centers did. We opened up our incident command center, which in the past had been open for maybe 3 days during a snowstorm in Atlanta, which means more than an inch and a half, and everything stops. But never anticipating this as a long-term organizational structure. But we opened up our incident command center, put together work groups on care models, on supply chain, on HR, on each of our put together an effective and efficient infrastructure in terms of working groups and put the right people on the groups. And myself and 5 of my colleagues, our chief operating officer, hospital group president, physician group president, chief medical officer, and chief nurse executive, the 6 of us became sort of it ended up being called the Team 6, only because sort of my executive assistant, when she had to schedule it, had to think of something. And it sort of evolved into the Incident Command Center Team 6. We met 2 hours every day with just the 6 of us, initially 7 days a week. And then in between, we had another 3 hours or so with the different work groups. So we were spending about 5 hours a day together working on pandemic response. And we still have 10 hours a week of, I take it back. We dropped down to 8 hours a week of the 6 of us getting together every, again, 5, now it's 5 days a week, not 7. But we still sit down and work together. And I think the key to facing the challenges, one was, again, optimism. A second was resilience, because, we found ourselves, as I'm sure you did as well, running out of N95 masks. What do? We're running out we can't get gowns. What do? Unbelievable workforce challenges, and just the resilience of saying, okay, this is just something else we got to solve. Let's sit down and do it, and let's do it together. What was really fascinating to watch was, we're an academic center, as you are up there. And whenever you're dealing with faculty and the kinds of curiosity, inquisitiveness, and skepticism one has in good academics, it tends to grind things to a halt from a decision-making process, because you always have more, not only the 1,000 points of no, of veto power in an academic matrixed organization, but oftentimes just the truly great questions people ask, questioning your decision, which truly are, questions you have to say, well, am I right in my assumptions? Let me really rethink this. And what the pandemic did was it caused us to recreate our decision processes. So something that would take us a year pre-pandemic would take us 2 weeks. Something that would have taken us 3 months would take us 3 days. And something that would have taken us, 3 days or a week, we made in our meeting with that right there and then, with the willingness to work with less clarity of data. And so really those together, made it a pleasure to deal with the pandemic. And I couldn't be prouder of the outcomes. Emory, we are fortunate Emory's expertise is in infectious disease. It's a top 5 infectious disease organization. So we were doing every major trial in therapeutics and almost all the vaccine trials were either organized through Emory or run through Emory. We have an oral antiviral that's in phase 3 trials now, being manufactured at generic factories in India, awaiting approval, which is an oral antiviral that's been shown in phase 2 trials to markedly impact, decrease the time of infection and the shedding, which for Delta variant, I think is going to be really important. So it was really, it's been a pleasure to work, but it's been tiring. And again, dealing with both just the physical exhaustion of the number of hours of meetings and work per day, and the emotional exhaustion of having, thousands of our coworkers come down with the disease. And knock on wood, the number we lost was less than a handful. But, each and every one of those 2 or 3 folks was a punch to the gut to lose anyone.
Well, that's remarkable, and you're right. We had a very similar approach to dealing with it with Incident Command, and it was an exhausting experience. But it was remarkable, I think, to see people come together with a singular focus, that we're working together. And that's what I really appreciated in our communities, is how disparate parts of the organization all came around with a singular focus, that we had a common challenge that we had to meet, and we all had to pitch in.
Yeah, it's interesting. Part of the cultural work that I emphasized in coming here was employee engagement, something I really dug into. I went into wholeheartedly at Hopkins in the department, and in my senior vice president role there before I left. But here we had engagement. We actually had our employee engagement survey scheduled. And I said, okay, we may as well just do it. And we'll, after people have been working short staffed and worried about supplies and everything, we did it about 2 months ago. And interestingly, our employee engagement went up. And I think it's actually not that surprising, because we're fighting a common enemy. We have a common purpose, and we're listening to every voice at every level more quickly, more efficiently, more effectively than we ever did before. And I think the employees feel that and see that. Having said that, things like work-life balance, clearly those scores went down. And, and some of the staffing scores, are you staffed? Do you feel you have adequate staff? Those, not surprisingly, went down, but the overall engagement went up during this time.
Well, maybe as we start to wind down, I wanted to finish off with a broader perspective, if you could share for our audience, which is healthcare. We've been through an enormous challenge. There will be great opportunities and challenges in the future. What do you think are the biggest 2 or 3 that we as a society, as a nation, will have to deal with over the next decade? And what is your best advice to current and future healthcare leaders to help meet those challenges?
Well, I think there are 3 major challenges, both to society, but also in particular to healthcare delivery organizations, whether it's an academic medical center or a community system or whoever is providing care. I think there are sort of 3 major issues that I worry about. The first is cost. Our healthcare system healthcare costs too much in the United States. And the issue we have is, the health system's response to that, to the cost of their, of their costs, is to work and negotiate with the insurance companies and try to use commercial insurance to cross-subsidize government care, Medicare, Medicaid, as well as uninsured. And, down here in Georgia, we don't even have Medicaid expansion. Which it's really, so we have a large uninsured population here, unnecessarily uninsured population. And we can't continually increase the burden on the commercial insurance, because ultimately those are employers, and the employers can't continue to increase how much they're paying for their employees. So as a nation, I think we've got to deal with cost, and as healthcare systems, we have to get ahead of that. And that was one of the reasons I put so much emphasis on lean and waste reduction when I first got here, and why we continue to invest heavily in making it a lean culture, and where waste is discovered and essentially eliminated. So cost is the first major challenge. The second is something that really, the Band-Aid was ripped off the wound with the pandemic, and that's workforce. We've been heading towards a workforce crisis for a number of years. And the number of retirements and folks just deciding that maybe healthcare wasn't for them during the pandemic has really shown what the workforce challenge is. But I know certainly in the Southeast, and I suspect it's not that different where you are, workforce challenges amongst nursing, amongst respiratory therapists, even CT technologists, and any highly trained member of the team is just incredible. And now post-pandemic, even things like call center people, it's impossible. We're staffing our call center. We continue to have to bring up incentives, push up wages just to staff a call center. And the challenge is, again, goes back to number one, is cost. We can't continually increase wages and not have to look towards increasing costs to society. So the workforce challenge is a huge one. And interestingly, the sort of remote work environment that was so successful for our COVID responses, where we went, close to 100%, anyone who wasn't seeing a patient was remote. The problem is it creates a challenge, because now we have people who are from high cost markets like New York and the Seattle and California, the Bay Area. They're now hiring our workers to be remote workers there at San Francisco rates, at San Francisco wages, which are tough to compete with. But people can live in Georgia and Cleveland and less expensive places and work wherever. So workforce is another one. And the third is we've seen the acceleration of disruptive business practices, destructive business initiatives, which for legacy healthcare systems, academic healthcare systems in particular, are a major threat. Because when Amazon can provide the well-compensated care that we have been doing, that have helped subsidize both our non-compensated care or our Medicare, Medicaid, or have compensated and helped to invest in our academic missions, when that higher reimbursed care is pulled out by these disruptors, what we're left with is an unsustainable business model. So we have to figure out how to disrupt our own legacy business. We have to figure out, how do we create our own digital front doors? How do we create our differential competencies to keep patients wanting to come to us, and not simply to go online to a doc in the box sitting in wherever they might be. And I think the keys to that are to remember why we went into medicine in the first place. It's built on empathy. It's built on compassion. And the more we can ensure we and all of our physicians and providers and other clinicians and staff keep empathy and compassion at the top of their lists of competencies, we'll succeed. And as soon as we forget that, we're in peril.
Well, thank you, John. Those were sage advice for all of us and the challenges that we will collectively face. Not unique to Emory or Atlanta or Cleveland. It's really a national challenge. And it's something that leaders like yourself and leaders around the nation will have to help us overcome. So thank you for those thoughts. Any concluding remarks, sir? This has been, just for me, an incredibly enjoyable hour. But any final remarks before we sign off?
Well, it's been a pleasure. And, I always enjoy these types of conversations, but I do have to preface it by saying, free advice is worth what you pay for. So everyone should take this with a grain of salt. But no, I really, this is what's worked for me. May not work for you, may not work for everyone. But I feel strongly this is a a formula that for me has been very successful over the years. And I think, really the key, I look to my education, my residency at UH, and I really, think that was such an important foundation to my career growth and my success. The humility that I found so many of our faculty and my colleagues showed, the commitment to taking care of patients and putting our patients first. Those really were our fundamental foundations to any success that I may have had. So I want to thank you and thank the University Hospitals community for inviting me to come out and talk to you this fall, and for enjoying, asking me to make some comments today. And again, I appreciate everything everything that you all are doing, keeping Cleveland safe and healthy. And look forward to seeing you in the fall. So stay well, everyone. Thanks for all of your attention.
Thank you, Dr. Lewin, and we look forward to your visit as well.